regular sessions, okay? Regular sessions, you can book in the Telegram group, okay? So, and if you don't want to do like random stations, guys, just DM me and give me the options of the stations that you will be, you can do, okay? So today's session is going to be like mock simulating the exam, and it's going to be with Dr. Hamid. Yeah, so can you hear me, Dr. Hamid? Dr. Hamid, can you hear me?
السلام عليكم دكتور علي. Should we send him a should we send him a text?
I texted him, but I don't know if he like, yeah, so you can text him, yeah?
My sound clear?
Yes, we can, yeah.
I'm not getting Dr. Ali sound clear. It's breaking a lot.
Okay, so
anyone else in the group, please speak so that I can understand.
Can you talk to Omar?
My side or from just.
Assalamu alaikum, Dr. Hamid. Can you hear me?
So, Dr. Hamid, reconnect.
Just a minute. Let me first check it. I will just.
Yeah, reconnect.
I can join it again.
Yeah. Hello, can you hear me now, Dr. Hamid?
Oh, we can hear you, Dr. Ali.
Yeah, but I think Dr. Hamid cannot hear me actually. So.
Do you think we can start with someone else and then come back to Dr. Hamid? What station were you planning to begin with?
Actually, today's session is mock exam with Dr. Hamid. He's going to do like 8 stations. That's why we are waiting for him. Actually, it's not just one station. It's going to be mock exam. But while we're waiting for Dr. Hamid, Dr. C, would you like to take any of the stations?
Yeah, I don't mind to do one.
Okay, so which station would you like to do?
I don't mind. You pick one.
Okay, so just 1 second. Let me look for the scenario. Dr. Omar.
ايوه دكتور حامد.
Yeah,
yep.
So like, can you do like this communication with Dr. Just 1 second, let me show you the screen. If you can do it with him as a patient, okay? Um, so Dr. C, I'm going to share the screen, okay?
Okay.
Yeah.
Okay, I've got that one.
So we still have a few seconds. Or you want to start?
Yep.
Okay, so yeah. Dr. Omar, can you do it with him or?
Yeah. I can do it with him.
Okay.
Oh, extremely sorry.
So let me set
Actually,
the time and then you can.
it's heavily raining. That's why that was line was disconnected. If you are continue, you can continue, and I will join next. So I'm ready now. Dr.
Yeah.
Ali?
So let's take this communication and then we can start with you, Dr. Hal, because we already gave
Okay.
Dr. C one.
Okay. Sorry.
Okay.
Sorry.
Yeah.
Extremely sorry. Yes.
Yeah. So like you can take your mock just in after like a few minutes. Yeah, Dr. C into the station.
Okay. So I'm coming in the room. I'm saying, knock, knock. Hello. My name's Dr. C. I'm working as an orthopedic SHO here. Can I check your name and date of birth, please?
Yeah, I'm John Smith, born 1st of January 1988.
Thank you, John. And now, is it all right if I have a chat to you about the operation that you're due to be having today?
Yeah, please. Yeah, I've been, I've been a bit pent up about it. It's my third time coming here.
Yes, and I know you've been waiting a long time, so this is going to be very sad news. But unfortunately, the consultant surgeon who was going to be doing this operation has been called away unexpectedly for an emergency. So unfortunately, your operation is going to have to be cancelled again. I'm very
I'm
sorry.
sorry. Yeah, no, this is unacceptable, doctor. Sorry, no, this is you can't be doing this. It's the third time I've been here, and
Yes.
I've had to take time off of work. I've already been off of work for months, and I don't live close too. Like you can't be that. You got to get someone else.
Yeah, I know how that must feel, and I wish I could do the operation for you, but I can't. It needs to be a consultant. And I understand what you're saying, that you've been waiting a long time, you've been off work, and things are very difficult, and another cancellation is the last thing you need. So I'm really sorry to be the bearer of bad news there.
Well, doctor, can't you just get another consultant? If it's a consultant you need, can you just go? Surely there's another one in this hospital.
Unfortunately, because although your operation is very important to you, of course, and it's important that it gets done, it's not in critical emergency that we can transfer surgeons from another hospital to come and do this. So it's only in very rare circumstances we can do that. And this, although as inconvenient as this is, your operation will still go ahead, and it won't jeopardize you, although for the frustration, a further delay. So unfortunately, that's not possible either. I'm very sorry.
Doctor, you're saying like it's it will still go ahead. It's my third time here and I'm in a lot of pain. Can you even guarantee that the next time I come, it's actually going to happen this time?
It's unlucky to be cancelled 3 times, and I suppose you can never say that it couldn't happen a fourth, but we would do everything in our power not to be, so you can never say never, but I would very much hope not so. And it would be a really unlucky roll of the dice to have an emergency like this happen on a subsequent occasion. So although no one can promise you, I really hope not, and I'm still, again, very sorry about it.
Yeah, all right. No, I get it, but I know it's not in your control. But what can you do next time round to ensure that that, you know, I have less of a chance to have it cancelled again on me.
Yeah. So the systems are as they are, and no one can predict emergencies. So unfortunately, it is a case of waiting until it gets done. But you are a priority now, and you're obviously, we're not going to be putting other people ahead of you when you've had 3 cancellations. So we very much hope that this very sad news and annoying situation won't be repeated. But there's no, I can't give you a cast iron guarantee. I'm sorry on that, but you know, we really will try.
Yeah, no, I'm sorry, that won't do for me. I would like to file a complaint.
Yeah, you're very much within your rights to do so, and I think you know, the department that would be very sympathetic to that, and they will probably respond in to that appropriately. And I can get the address and the email of who you can write to, because I do understand, and I might be the same.
What department is that, Doctor?
So we have you know, a complaints department that's that deals with patient complaints, and you know, you've got good grounds to complain that you've had these unforeseeable delays, you know, so I can get you the email address for that.
All right, thank you, Doctor. That's something. So, what about the pain in my knee? It's getting worse.
Yes, so we could give you some further pain relief. I don't know if you're taking some today, if you've had some already or taking it at the moment.
Yeah, I'm taking some. Yeah, but it's not doing it anymore for me.
Yeah. We could ask the pain team to look at that in the very short term until they manage to schedule you, which we're hoping wouldn't be too long. I can do that. I can call them and ask them to come and see if there's anything that they can do in the short time. I will do that.
All right. I've actually also started to develop a bit of tummy pain.
Oh, right. What medication have you been taking up to this point for pain? And perhaps that's related. Can we investigate?
Codeine.
Right. So you've been taking codeine for some time and you're now getting upset stomach.
Yeah.
Can you tell me a little bit more about the upset pain? Is it like constipation or
3 minutes remaining.
Yeah. So it's like a dull aching pain with a little bit of constipation. Yeah.
Yeah. Well, that could well be from what, you know, we haven't investigated it fully, but from what you're saying, it could be from the extensive use of codeine that you've been taking. And that's something we have to balance when taking these medications for pain relief. And perhaps we could consider with the pain team swapping over to a different morphine variant that perhaps isn't so constipating or is not a tablet. I mean, that's something we can do in the very short term. And again, I'm very sorry that we're having to go down this road.
That's all right, Doctor. That's fine. I mean, it's bound to happen at this point. I do live quite a big distance away. Like, I can't keep doing this distance. So, like, is there anything you could do for me for that? Because it's a lot of time and it's a lot of money to make this trip.
Okay. I will send an email about that. I understand you've had the expenses of keep coming in, and you do. I don't know the system on reimbursement of expenses and the rules, but I will find out for you, and I will update you whether either way, whatever they say, I will update you.
Okay. And what about my job? Because it's been a few months now. It's been like 3 months.
Is there anything I can do to help write a letter to your employer to say that, you know, this is out of your control and it's not you, it's us? Would that help at all?
Yeah. If you could do that, that would be brilliant.
Okay, so I'll put that on the list to do a letter that I can copy to you that you can send to them along with the pain and medication and the expenses.
Great, thank you, Doctor. I've just got the overarching problem, worry I've got is that this weight might do more damage to my knee. Like, is that possible?
I think long term, the problem that you're possibly dealing with is a meniscus tear, which stops you walking so much on it. And because of that, in a way, the pain and the discomfort stops you, doing any more damage to a certain extent. So that's one of the sort of mechanisms of pain. It alerts your body to something that's rough or causing a tear or causing problems. So in a way that you're moving less and not adding to the damage because it hurts for you to move it. So to an extent, a short-term delay shouldn't add significant damage to that, and the pain is letting you know that it's not good to do a lot of exercise on it at the moment. So I wouldn't worry too much about that aspect of it.
Thank you, Doctor. You
Fair
mentioned
enough.
something called Mendes.
Fair enough.
Yes.
Yeah, thank you so much. I'm going to give you a quick feedback. Actually, well done, Dr. C. And like I felt like it's real, and you're talking to a real patient. And actually, we're going to ask Dr. Omar as an actor. We're going to ask his opinion. So it's very important to make sense and to do it as in a real life situation. And you did it actually that way. So you did it in a real life situation. So just don't forget to wash your hands, even in communication stations, guys. If there's hand sanitizer, sanitize your hands. Okay. And I remember the advice of one of the examiners when I had this station at the prep course of the Royal College. So like was saying, guys, take personal responsibility. So like just personal. So they need to hear that. So I'll personally contact the team, and I'll personally get back to you about the date, about the rescheduling and these things. Okay. And like the phone number of the patient will be provided in the preparatory station. If it's not provided, you can even ask them to provide you with their contact, just by making it more real. Or if you have the phone number in the preparatory station, just confirm it with them. So is your phone number end with 475? And yeah, and like you took some some personal responsibilities. You're going to email the employer, you're going to email the find out about the hospital and the financial problem he's facing. Yeah, so that's very good. But sometimes the patient will be more angry. So it depends on the actor you are going to get in the exam. So they need to hear that you will personally contact them and make it again in real life. We need to confirm their contact details. Okay. For pain relief, if he's having stomach problem, just offer something topical. It's much better than offer him something to oral pain relief. So topical pain relief is a better option. Okay. And remember, this patient, one of the things, offer something for this patient to drink or eat. So this patient have been fasting for the operation. Yeah. So offer something for the patient to drink or to eat. Yeah. So, and overall was very good. Dr. Omar, you have the mic. So just so you can give us your feedback as well.
Yeah, no, thank you, Doctor. No, and pretty much everything you're saying, you're right. Yep. With regarding to the offering the patient something to eat or drink, yeah, just make sure you remember to do that close to the beginning of the conversation. Yeah, so that he's not you haven't done the entire conversation, then offer him, water and food and stuff like that. It's usually best to do it at the beginning. I tried to pin you down several times to get to commit to saying it will not be cancelled again, and you managed to deal with that well, to saying that we can't guarantee that all the time. So I think you realized I was trying to corner you to saying it, or getting you to commit to saying it, but yeah, you handled that well. With regards to the pain, the knee pain, if you could offer something a bit more substantive by saying I could actually examine the knee, also see if there's any inflammation, maybe take bloods to see if your inflammatory markers are up, so we can try and identify what could, if there is another cause, as well as referring you to physios for strengthening the that was that would be my only sort of criticism for you to put into with regards to the knee pain. But other than that, it was good. I was about to ask you, because you mentioned meniscus, I was about to say I've never heard of that. What is that? So had we had more time, I'd have gotten you to explain what a meniscus is, what its job is, and all of that stuff. But yeah, so that was okay overall.
Thank you.
Okay, thank you. And so we are going to start our mock with Dr. Hamid. So Dr. Hamid, are you ready?
Yeah, yeah.
Yeah. Okay. So so it's going to be non-stop then. So like the last time. Okay.
Right.
Let me start with sharing the screen for the first station.
Sorry, can I ask a question about the pain? When the patient asks that the drug they are using is actually not working again, what are you supposed to tell them? Are you supposed to offer them a different kind of drug? I heard Dr.
So,
talking about technical and
so you were like you are breaking, Dr. Iso. You're breaking up actually, so we can't hear you well. But anyway, because guys, we don't want to take
Okay,
long, so
yes,
we can
sorry,
take the
sorry.
questions
I,
at
I
the
was
end
asking a
and the
question
questions
about.
and the comment. So we can take the questions and the comment at the end because
Okay,
I don't know,
okay.
Dr. Hamid, I think he's busy. Like,
No,
All
no
right.
problem. No
No
problem.
problem. Thank
okay,
you.
because so we
Yeah,
can
yeah.
take all your questions, guys, at the end. Okay, because we can't
All
hear
right,
you,
thank
Dr.
you.
Matthew. Okay, so is
Thank you,
it
thank you,
okay?
thank you. Thank
Oh,
you.
we can
I'll
hear you
note
now.
that.
So
Yeah, well, I was going to ask that for the pain, if the patient is saying that he has been on some medications and the medications are not working for the pain, are we supposed to offer a different level of analgesia, like going up the WHO step ladder, or just the topical analgesia will be enough? And then I heard the other doctor, Dr. Mao, recommending that you do a further examination of the knee, investigation for inflammatory markers, and just trying to find out a possible other cause. Would that suffice?
yeah. So
Thank you.
actually, what the scenario repeated in the exam because of the stomach problem. That's why he's asking about the changing of medication. So if this the scenario he asked to change the medication because of the stomach problem over something topical. But if the medication didn't relieve his pain, so you can offer something else, yeah, stronger. So as he did, and yeah, if the problem is just stomach problem, but if the scenario is it's not helping with the pain, the ibuprofen is taking, it's not helping with the pain, so you can investigate further, you can offer something stronger, yeah. So it depends on the scenario how the patient asks you this. Okay.
All right. Thank you, sir. Thank you.
You're welcome. So yeah, so let's start, Dr. Hamid.
Okay, can I start?
So you will be wearing your gloves outside the station, okay?
Okay, yes.
Just wear your gloves before you enter the station. Enter the
So
station.
good afternoon. This is my
Yeah.
candidate number.
Good afternoon. Yeah, you can proceed with the patient.
Hello, myself, Dr. Hamidul Karim, one of the surgical doctors here. May I know your name and age, please?
Adam Stenson, I'm 25.
Okay, Adam. So you have got injured your thigh. I just came to know in an emergency you have been admitted here. Mr. Adam, let me see where you have got injury. Okay. Are you having pain at present, severe pain?
No,
Are you
no.
comfortable? Okay, thank you.
Yes, welcome.
So, Adam, you have just injured your thigh, and I will just check the wound, see the pulses. Are you feeling? I'm just trying to touch it with this. Are you feeling?
Yes.
Are you feeling? Okay.
Yes.
So, Mr. Adam, you have got around the 5 centimeter wound on your thigh. It's a little bit clean. It's not much contaminated. I just want to know, have you got any allergy to any of the medicines or any of the
Yes, I'm
solutions,
allergic to
soaps?
penicillin.
Okay, you have got allergy to penicillin. Adam, do you remember any immunization? You have got any injections of tetanus or something? How long you have got?
Yeah,
Do
I
you
think I'm
remember
up to
any?
date with, yes, I think I'm up to date with my tetanus.
Okay. So, Adam, what I'm going to do is that I will be just cleaning it and with the solution, then covering it with the sheet, and then giving a small injection. It is a numbing agent, what we call is as anesthesia agent. So that will help to numb that field, and then I will stitch. You will be hardly requiring 4 to 5 stitches. Then I will just dress it after that. Is it okay for you?
Yes, that's fine.
So, Mr. Adam, have you signed the consent form?
You don't need consent.
Have you?
You're people.
Okay,
You don't
sorry.
need consent.
So, is the assistant and can I see the WHO checklist?
Confirmed.
Okay, confirm right side. Adam, have you got the wristband? Okay. So let me just prepare my trolley instruments. So, Mr. Adam, till that for 1 minute, I will be just asking the assistant, can you check this uh, date of expiry? It's around 29. It's
Yeah.
okay. And this is a anesthesia agent, and this is a numbing agent. Can you check
So the
this? It is
anesthesia given
also
already, doctor. So the
okay.
anesthesia
Sorry.
is already given, yeah.
So this person is already anesthesia is given and it is already draped. So what I will do, so now it's already numb. So what I will do, this is, Adam, I will be just taking few stitches. And if you, let me check it first. Are you feeling at your wound? Are you
No,
feeling at your wound? Okay,
no.
nice. So now, Mr. Adam, this stitches I will be taking on your wound, and that requires a dressing afterward. So you will hardly get
So,
3 to 4
you mentioned how many
stitches,
stitches, doctor? How many?
roughly 5 stitches you will require. And what we'll do, after taking these stitches, we will apply a dressing. And most probably that dressing will be waterproof. So these stitches, what we call it is that it doesn't get dissolved of its own. So Mr. Adam, what you need is that you need to come for the dressing or you need to come for the stitch removal of the stitches. So any question you have regarding these stitches?
Yeah, so when I got remove them, you said when?
So it will be removed after 8 to 10 days. So depending upon that wound. And after doing this, what I will do, I will write a letter to your GP so that he can guide you further. So these stitches will be, as you have got a clean wound, that's why it will be removed up to 7 to 8 days also. It depends upon. So let me cover a few stitches and then I will write a letter to that GP.
Okay, so how often do I need to change the dressing?
So if I apply a waterproof dressing, so what you will do is that you can take a bath and then after 3 to 4 days, if suppose you get any wound is this your dressing is getting soaked or supposed to be getting swell, you are get some swelling or something, we will change the dressing in between. Otherwise, there is no need of changing it till we remove the
So
stitches.
do I need to come back to you to change the dressing and remove the stitches?
So I will just give a letter to your GP where whoever is nearby and he can also do it. Or if for not possible, I will give you my number. You can contact me and come to our hospital. No issue.
Okay. All right.
So these are the stitch. So once I finish,
3 minutes remaining. So the examiner will ask you now. So which suture you can use to close the skin
okay.
of the
So
lower limb?
thank you, Adam. I will just come you will write later. So the stitches required for suturing the lower limb will be Ethylone or Prolene synthetic suture with the help of cutting needle around 30 or 40.
Okay, what's the dose of lidocaine?
It's if it's a plain lignocaine, 3 milligram per kg. If it is with the adrenaline, it will be around 7 milligram per kg.
Okay, and what the maximum dose?
Maximum dose is it should be measured from the weight of the patient, and then we have to if suppose it is 1% lignocaine, then it will be having around 10 milligram per ml. So we go out 3 milligram per kg will be the maximum dose. We have to calculate from the weight of the patient. So,
So
it
if the
can be
patient is 70 kilograms, how much you are going to give?
70 kg into 3, it can be around 210 milligram. So 1% lignocaine will be having 10 milligrams. So around 20 ml will be the maximum dose for 70 kg person. If it is 1% plain lignocaine.
Okay, so I finished my questions. So anything else you would like to do?
I'd like to write a letter and just dispose all these sharps into the sharpest waste, and the gloves and the sharps into the other waste, and then write a letter to discharge letter to the patient.
Okay, thank you. So that's the end of the station. You can wait until the bell ring, okay?
Thank you.
So now we are going to go to the next station. So I'll give you the scenario and 1 minute for the scenario, and then you can answer the question. Dr. Omar, are you ready?
Yep, I'm
Yes.
ready.
Yeah, so enter the station.
This is my candidate number.
Yeah, so you can you can proceed with the patient.
Hello, myself, Dr.
Hello.
Hamid, one of the surgical doctors here. May I know your name and age, please?
Yes, doctor. My name is Omar Seri, and I'm 23.
So can I call you Mr. Omar?
Yeah, it's fine. Yeah.
Okay. So Mr. Omar, why have you been to the hospital? How can I help you?
I've got a back pain, doctor, and it's getting worse and worse.
Oh, so sorry. So are you comfortable? Can you discuss with me, or do you need any painkillers?
Yeah, I think I can stand a conversation.
Okay. Please be with us for some time. I just want to inquire a few of the things. When did you get this back pain? Since how long you are getting it?
It's been about 2 months now, doctor.
And can you point out me exactly where on this, on your back? Where can you
Yeah,
point
it's
out?
in my lower back, like right just above my buttock region.
Okay. So are you getting, how can you describe this pain? Is it dull or it is sharp shooting like that? How do you get this type of pain?
It's like a cramping pain. And it's I'm feeling it. It was just in my back, but I'm feeling it like in my buttocks now as well.
Okay. Is it moving somewhere else from that side, from the back? Is it moving towards the legs or
Yeah, from
somewhere
the
else?
back down to the buttocks. Yeah, and yeah, a bit in my thighs. Yeah.
Okay. Have you got any idea when does it increase? Whole day you get it, or early morning when you get up? Or have you got any
I
relation
get
with
it
that?
all day, but it gets worse when I keep moving.
And what does it relieve? Means when you get comfortable, is it by lying down, sitting, or how is it?
Yeah, when I lie down, it feels just a little bit better, but it's
Oh,
just
okay.
it's reached the point where it's hurting all the time now.
Okay, okay. Mr. Omar, can you please scale the pain from 0 to 10, where it can be?
With what would be 1 and what would be 10?
0. 0 is nothing. 0 is nothing. And 10
Mhm.
is the severe pain, which is not
Yep.
intolerable.
Yeah, so like 7.
Okay, okay. So sorry, it's very painful. So have you
Mm.
got such a history in the past? Means similar type of pain, 6 months or 1 year
No,
or back something?
no,
Okay. So have you got anything related to the medicine? Are you taking any medicines, painkillers for that?
yeah. I'm taking tramadol and I'm taking morphine for it.
Since how long you are taking it?
For 1 month. 1 month.
Okay. Okay. Since 1 month you are getting it. And
Yeah.
do you have got any medical problems like blood pressure or sugar, diabetes like this?
No, no,
So have you got anyone in your family having similar type of complaints like
no,
a severe backache or something? Okay. Have you got any allergy to any of the medicines or drugs or something?
no,
So have you got any pain in your knees or any rashes over the body,
no,
like redness or some itching over the body, any eye difficulty, redness in the eyes?
no.
So what do you understand about this, and what job you do?
I used to be. I was an office worker, but I've noticed that I've got like other problems as well. Like I mean, it's a little bit sensitive, doctor, but I've got uh, problems down
Have you
there.
ever traveling? Have you ever traveling a lot? How do you commute daily? And where do you stay? How long you are staying and traveling?
Oh no, traveling's fine. So it's a short
What
distance.
about your weight? Are you increasing or unintentional loss in the weight?
No,
Do you lift the heavy weight, do exercise or gymming or something like that?
no.
And what are you concerned about this? What information you have regarding this?
Well, just the pain, doctor. Like I want to know what's the cause of it, and like I said, I have some problems kind of like down there.
And what are you exactly expecting from the hospital or the doctors?
Just to find out what the what the cause is and how can you treat me, because
Oh, fine, fine.
the pain's bad. Yeah.
Okay, Mr. Umar, we will definitely go through detail and discuss with the consultant and do some of the investigations. Do you need anything related with this? You want to say something about this?
No. Just that and
So,
yeah.
so Mr. Umar, let me clear you that you have got such type of pain since 2 to 3 months. You are getting a lot of painkillers and you are worried that you are not able to do routine daily activities. That's why you have come to the hospital and you want to get it investigated and then getting treated for that. Is it okay?
Yeah.
Yeah, I will. Thank you very much. I will come back to you and consult with my consultant and just inform you.
Okay. Thank you, doctor.
Okay, doctor, the patient mentioned he have something sensitive you want to discuss.
Hello, may I?
Yeah,
Please
so the
repeat it.
patient mentioned he has something sensitive. We still have time. Do you want to discuss the sensitive issue with you?
So Mr. Omar, have you having some
Yeah.
sensitive issue? Just I want to ask few of the things that personal. Is it personal? It will be between you and me. And have you got any trouble with your maintaining
Time up.
erection or like that?
Time up. 3 minutes remaining.
Okay, I'll just taken the history of Mr. Umar, 25 years man. He has got a back pain since last 2 to 3 months, and he is constantly taking painkillers, and he is little bit worried about that and getting back pain and daily activities ourselves. And he has some information which I could not take. And if suppose I get time, I will inquire about some of the personal factors like maintaining erection, all that. But as per the history which I completed, I would like to, after doing examination, the most probable my diagnosis is first is mechanical back pain.
Okay, what are the differential diagnoses?
So other possibilities can be a lumbar disc prolapse, cauda equina syndrome, or a patient having any of the tumor compressing on the spinal cords.
So, doctor, this patient mentioned he's having sensitive issue and he's having claudication. So, and buttocks claudication and thighs claudication. So, what could be your top differential diagnosis?
Claudication, it can be neurogenic.
Can you come again?
Yes, claudication. Patient
Yeah, so he
mentioned,
mentioned he's having buttocks claudication. Yeah.
so that is the buttock pain. So he is feeling as if since near the buttocks, he has got something just he's sitting on the cushion like, and that feeling is something awkward feeling for him. That may be because of cauda equina syndrome, compression of the nerves surrounding the
Connection or
area.
the habit connection, I think. Yeah.
I'm not getting voice.
Yeah, I can hear you now. So, what's your top differential diagnosis? He's
So it can
getting
be the
claudication and he's having erectile dysfunction. So that's the sensitive issue we want to discuss with you. So, what's your differential diagnosis?
so it can be a atherosclerosis over the this vessels at the he can be it's because of irritation of this nerves and he's not getting a proper erection. That can be one of the cause, like important
So, what the
syndrome and all
diagnosis?
that.
So, what the diagnosis is there?
So if that if I get the history and investigation after that, I will confirm if it is a Leary syndrome or something like that.
What's Leary syndrome?
It's because of the clotting of the common femoral arteries, saddle like embolus or something like common femoral artery, which doesn't supply the blood to the dorsal artery of the penis, and cavernous cannot be getting during erection. The patient cannot get proper erection. That is a part of lyric syndrome.
Okay, time up. Thank you. You can go to the next station now. Thank you. Let me give you the next station.
حضرتك تحبني في ستيشن تاني في ستيشن
Yeah, you have another station. Yeah.
تمام.
You're going to do the communication, Dr. This examination station.
Okay. Oh yes, sorry. Communication. Yeah.
Into the station.
My candidate number.
Yes, so you can proceed with the patient.
Hello, myself, Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
Emily White, 50.
So, Emily, so I'm Dr. Hamid. I will be examining your head, your ear. I just came to know that you have got a history of fall. and that's why you got some hearing loss. So I will be examining your ear, some of the nerves which are arising from your brain that involves looking at your face, doing some of the movements, checking your ear, testing it from inside with one instrument. Is it okay for you?
Yes, that's fine.
So are you having any pain or giddiness or something? It means you are feeling something giddy, and then I will give some medication if you want. Is it okay?
No, I don't have pain right now.
So Emily, just let me see it from the front first. So you got this injury on the right ear. Okay. So I will be seeing from front. So let me just touch it. Are you getting pain here?
It's just a little bit, yeah.
Okay. Okay, fine. So Emily, I just want to check some of the changes in your face. Can you please raise your eyebrows like this? Thank you. Can you tightly close your eyes? Let me see. Okay, fine. Can you blow your cheeks? Fine. Can you tense your this? Very good. So just let me check some of the things. I will be talking from behind. Can you repeat the words? 22,
No, they can't hear on the left side.
22. So I will be just putting this, if the hammer is there or this tuning fork is there, I'll be just trying to, can you listen the sounds on both ear?
Yes, it's
So
loud on the
I
right side.
slow on the right. So I'll be just putting this hammer on your bone from here. And once you stop hearing, I will keep in front. Let me please know it.
Okay.
Are you
Yes,
getting
I
it?
can hear that.
Now can you
Stopped.
hear it? Okay.
No, can't hear it now.
So is there otoscope here on the trolley? Otoscope? So if the otoscope is here, I will be just checking the ear inside. If it's not there, I will be just asking him to, can you please stand? And you close your eyes and make your hands like this. Thank you. Thank you. Please sit down. It's okay. Emily, Miss Emily, I will be just consulting with one of my consultants and come back to you for this. Do you need anything you want to, you have any question to ask to me?
So, Doctor, anything else you'd like to do? There's otoscope inside the station.
That's why I'm asking. Your scope is there, so I will be just putting this, checking your ear inside. So I will be, just Emily, I will be just holding your ear from here and just change the cap and see inside. And dispose this in this, and from this ear, left ear, it's okay. So I just examined Miss Emily, 50 years old. She had history of fall and injured on the right side of his ear. And on examination, the person, she has got vital sign positive, as well as the Weber's test is lateralizing from the right ear and so this is a possibility considering her head injury. It can be first primary diagnosis is fracture to the base of skull with conductive deafness on the right side.
So, what are the causes of conductive hearing loss?
So it can be because of impaction of the lot of wax here, or there can be otosclerosis, the bones get fused each other, or it can be some foreign
3
body
minutes
impacted
remain.
in the, it can be the foreign body impacted.
Okay,
in the-
last. How do you perceive this patient after you saw the connection or Dr. Hamid's connection?
أو
Yeah.
الكونكشن
Network
بتاع
is
حضرتك
not okay.
بس
So can
اتحسن
you hear me
دلوقتي.
guys? Am I audible?
Yeah, it's better.
I'm not getting any screen. Is it? Are you showing some screen?
Dr. Hamid, can you hear me now?
Yeah, I'm
Yeah,
hearing it.
can you reconnect, please? Can you reconnect?
Oh, should I disconnect and again reconnect?
Yes. Okay, can you hear me now?
Yeah, I'm getting a voice.
Hello?
Hello, voice.
Yes, so you proceed.
So this is a crisp protocol. I will go from C as the person it and any other injuries. Initial investigation, apart from the lab routine blood investigation, special investigation required will be CT scan, and then the person involving the multi-dimensional team involvement and the intensivist.
Okay, so thank you. Then you can go to the station. So I'll give you some time to sort out your connection, Dr. Hamid.
Okay. Just I will just
Yeah,
check it
so
again. So people there, are you getting my voice? I just not sure about that. Then
yes, okay.
okay.
So let's go to the next station. Dr. Omar, are you ready? Dr. Omar?
Yeah, we are listening you.
Okay.
So, Mrs. Brown, I'm Dr. Hamid, one of the surgical doctors in this orthopedic department. I just came to know that you want a certain information regarding your hip surgery. Is it okay? Which hip you are having? Is it okay for you, Mrs. Brown?
Yeah, it's my right hip.
Okay, right hip. So, Mrs. Brown, let me tell you a few of the things which you want to check. How long you are having a problem with this hip?
I can't quite.
Okay.
Yeah. Where
Osteoarthritis. So you are having a pain in medicines for that to get okay and got some investigation.
your thing that you just mentioned there.
Understand few of the things from your side, then I will exactly explain. Have you got any problem with your blood pressure, sugar, or is it there? Any
No.
medicine you are taking? Is not taking any of the medications. Any?
So,
Have you
Dr.
got
Hamid, would you like to see the
Yeah,
scenario
yeah.
again? Can you hear me?
problem with the knee? Yes, I'm getting it. You got a problem with the knee that is called, you have two bones in the joint. This is just like your upper bone and this is the lower bone. Two bones, when they come together and they form a joint, and the ends of the two bones, when they get a little bit cracky, they get rubbing each other, that leads to roughness on the joint, and that is called as osteoarthritis. So this is the problem with your right hip. As you are aged around age 66 or 67 years, artificial joint, what we call as a artificial joint. It can be either of a steel or it can be of the plastic type of instrument. So that total joint is removed. So that is called as total hip replacement. Are you getting this? I've got
Yeah.
this
So
idea.
how does
To our orthopedic surgeon and the expert team and all the anesthetists and all diabetes, sugar, everything, we check it and give a numbing agent that is called, we call this as anesthesia. And this numbing agent is given by a small prick on the back, generally on the back, and that makes the total limbs below your surgery, where orthopedic surgeon removes your damaged rough surfaces total with the head and all that, and then replace it with the steel. So then you get all the wound, means whatever wound is there, that is all stitched. Then after second or third day, you can be able to walk. And this type of surgery, it generally lasts for around 1 to 1.5 hours. Then you are asked to walk on the crutches. Then you will be asked to walk a little bit. So have you got any idea? Do you want some more information about this?
Yeah. So when can I go home?
So generally, this is a surgery. We call it as a major, means 1 to 2 hours. And if suppose it is done very smoothly without any problem, you can be discharged third day or fourth day within 2 to 3 days. It doesn't require much admission. And one of our physiotherapist, will be guiding you what to do at home and how to walk and how to bear the weight, put the weight on your legs and all that. Do you need
So,
anything in?
Doctor, yeah, thank you. So, I'm quite, independent, and I like to drive. When can I drive?
Actually, in this, immediately you should not drive for at least 1 to 2 months unless the things become strong enough. So it's better to avoid at least for 2 months. You should not yourself drive because it requires a lot of mechanical movements on your joint. So it will be better. So and you are alone, so you can walk it, but driving and running, this is a little bit more physical activity that should be avoided.
So, doctor, complications that can happen from it?
So as all the surgeries have got little bit complications, and but our team is trying to monitor it, means watch it very carefully to avoid that. So few of the complications can happen is that the commonest thing is that whatever wound is there, that may get little bit oozing from the wound, or it's this artificial that may cause pain afterward, or immediately during surgery, some of the blood pressure may rise, or some of the blood, you say small clots, what we call it as a small, this can be there in your limbs. So for that, we will going to take few strong measures for that.
Okay. This blood clot sounds kind of dangerous. How are you gonna prevent that if it
So we
happens?
will definitely,
I forgot to say
definitely,
3 minutes,
that's a
not 2
very,
minutes left.
I would say it's a very good question. Actually, we do it surgery and just we try to avoid. Basically, this type of clots are formed in your legs if you are lying for a long time post surgery. So we avoid it by putting some of the mechanical compression devices on your leg, and early we try to move you early, mobilize you early. So this will be avoided.
I see. Okay. And when do
Are
I
you fine? Yeah,
pardon?
are you? If you are fine with the, if you are fine with all the things, I will just take consent from you, and you post you as early as possible with
No,
discussing
no.
with our
Before
team.
that, no. I want to take some time to think about it, doctor. But before the surgery, because now I'll go home, think about it. And if I do agree to the surgery, is there anything I should be worried about when I come back home from the surgery that I might need to come to the hospital for?
So the thing is that once you have been discharged to the home, and your stitches will be along with you because you will be early discharged. This suturing stitches which we are giving, that to be taken care, the bedding and all that and movements, and you have to come back to the hospital for removal of these stitches. Then for some of the physiotherapists will advise you the various type of exercises, and the rest of the things you have to think that wound should not, if you go home and you see that your hip is, that hip area is swelling, means increasing in size, you are getting severe pain or some numbing sensation on your leg, that's things, these are the things which have to be kept in your mind, and you can call me, I will be available for you, or message me.
Doctor, that sounds, sounds quite scary. Like all of these potential complications and stuff. Is there anything else we could do, other than surgery?
Actually, I can understand this. Everyone gets worried about such type of things, but this surgery helps a lot to gain your activity more. So we can just continue with some of the treatment like painkillers and all that. But finally, this will help you a lot. So you just think it with a cool mind that if you want to come,
Thank
okay,
you.
I will just, yes.
Yeah, you can go to the next station now.
Okay, thank you.
Okay.
Hello, may I enter?
Yes, into the session.
This is my candidate number.
Thank you. So you can proceed with the question.
Good afternoon. Myself, Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
Emma Smith, and I'm 25.
Emma. So I just got that you have got an injury on your left shoulder. So I will be checking your shoulder. It involves looking at your joint on this left shoulder and from the front, from side, from behind, touching it, feeling it, doing some of the movements. Are you having pain at present?
No,
Okay, thank you. So just Emma, will you please stand up? And just
can you?
can you walk straight and move your hands like this? Can you please come back? Thank you. So will you please push this wall like this, little bit? Will you please push this wall? Thank you. Can you please sit down? So yeah, I removed this, actually gone is there, I removed it. I will just checking your shoulder from here. Have you ever injured this back some days back or years back? Have got any? I can't see any scar. Okay. Miss Emma, I will be just touching it. Are you getting pain? You please let me know. So are you getting pain here
No,
on this side? Okay. Miss Emma, just will you please stand up? Can you move your shoulder, hands like this?
so there's restriction on the left side, so she can't like move the left side like fully. So there's restriction in the movement of the left side.
Can you make it behind? Okay.
Yes, there's restriction on the left side as well.
So Miss Emma, please can you just lift your shoulder slowly? I can see it. Okay. Okay. Can you bring it down slowly? Fine. So will you please keep it like this and move it like this? Okay. Can you make your shoulder like this? Thank you. So I will be just checking it myself. Are you getting pain on the ear?
No,
Are you getting pain like?
no.
Okay. So Miss Emma, will you please, I will be just doing some of the test movements. So can you make it like this? Bring your thumbs like this. I will be pushing it down. You try
So
to
easily
resist it.
collapse. The left shoulder, the left side easily collapse.
Okay, okay. So will you please make your shoulder, just look at me. I'm just moving it like this. This shoulder like this behind. Will you please push my hand? Okay. So Miss Emma, please sit down. Just close your eyes. I will be just touching here. And you say me that, are you feeling it?
Yes,
Can you feel?
yes,
Okay. Can you feel here?
yes.
Okay. So Ms. Emma, I will be just coming back, discuss with the consultant and come back to you with the problem. And
Okay.
so I have examined Miss Emma, a 25 years lady. She had a history of fall and injured on the left shoulder. And on inspection, there is no scar. And palpation, there is tenderness at the joint on the left shoulder, acromioclavicular joint as well as shoulder joint. And some of the tests, like she has restricted movements on the left shoulder. She has got a painful arc as well as the positive drop arm test. She is unable to lift the arm up properly. And even she has got this Job's test is also positive. Most probably, she looking at this clinical examination, I'd like to do complete neurological investigation and radiological investigations.
So
And
what are your differential diagnosis?
probable diagnosis is supraspinatus muscle tear, part of rotator cuff tear. And the differentials can be she has got ligamental injury, coracoaccular ligamental injury, or fracture at near the shoulder joint, near the clavicle. And so these are the
Okay.
possible.
So in the examination, how to differentiate between frozen shoulder and rotator cuff tear?
Rotator cuff, the frozen shoulder has got global restriction of the movements. All the movements are restricted in frozen. While in rotator cuff tear, the drop down test, the drop test is positive. Means person cannot lift the shoulder and cannot bring it smoothly. So this is the basic difference in the frozen shoulder and the spinal tear.
Okay, how do you
Sure.
proceed with this patient?
Along with the basic investigation, blood investigations for inflammatory markers and all that, the patient needs specific investigation for the X-ray of the AP lateral joint, and then MRI of the joint especially is required to understand the muscle tear. And this start with the initial conservative treatment, physiotherapy, anti-inflammatory drugs, and some fermentation, all that. If these conservative patients is not completely recovered, she may require multidisciplinary treatment, requiring orthopedic consultation and repair of that rotator cuff.
Okay, thank you. So that's the end of the questions. You can wait until the bell ring, okay?
Thank you.
So let's go to the next station. Okay, enter the station.
This is my candidate number.
Yeah, thank you. Have a seat.
Just thank you.
Have you read and understood the scenario?
Yes, the
So
patient is having
what are your differential diagnosis?
the patient, depending upon the painless hematuria, there can be renal cell carcinoma or bladder cancer or any bleeding disorder.
Okay, so this patient is having polycythemia. What's polycythemia?
And this is the increased number of the number of cells, that is just myeloproliferative disorder, just like most of the malignancies like renal cell carcinoma has got stimulation for the
So, doctor, which
bone marrow.
cells could increase? So you mentioned increased number of cells. Which cells?
RBCs are increased, red blood cells are increased.
Okay, so what is the normal RBCs count?
It's around 5 lakh per ml per 5 lakhs to 8 lakhs.
Can you repeat again the answer?
It's 5 into 10 raised to 5. It's around 5 to 10 lakhs.
Okay, so what the cause of polycythemia in this case?
So in most of these paraneoplastic, whenever the malignancy of the kidney, something is there, there is a adenoma or malignancy. So that leads to stimulation. A lot of erythropoietin is formed that stimulates the bone marrow to increase the number of cells in the blood. That is
So I didn't
polycythemia.
get the answer. So guys, can you hear me? I don't know if you can hear me.
Yeah,
Just
I'm getting your voice. Your voice is breaking. Anyone else? Others are getting the voice?
yes, so I can hear you now. So you mentioned
So
what the
it is
cause of polycythemia in this patient.
erythropoietin. The erythropoietin is secreted much
So what's
because of.
erythropoietin? What's erythropoietin?
So it is a erythropoietin is produced into the kidneys by the fibroblasts. It is that the stimulant for
So what
that is a
is it? Enzyme, hormone, or what's erythropoietin?
it's just like a hormone which stimulates. It's a enzyme, basically enzyme which stimulates the myeloproliferative cells to form the RBCs.
Okay, so can you mention three causes for polycythemia apart from this one?
So it can be most of the malignancies of the blood itself, polycythemia vera or polycythemia rubra. It can be because of bone marrow itself is abnormal or excessive stimulation because of tumors in the kidneys. That is one of the reasons.
Okay, so is it dangerous, the polycythemia? Is it dangerous?
So it increases the blood viscosity that can cause most of the clotting abnormalities, and that may lead to blood clots as well as infarction or necrosis of the any of the organs if the clots gets lodged.
So can you define thrombosis?
Thrombosis is it's a intravascular blood clotting, and that has got specific lines of Zahn, and it is red colored, and that is attached to the vessel wall inside.
So what's embolus?
Embolus are the free, it is just like a free clots which can be freely moving anywhere from that vessel to any of the end organs or any of the peripheral structures in the body. That is embolus.
So what the pathogenesis of DVT?
So the deep venous thrombosis depends upon the three basic things. One is blood viscosity. If it is increased, the second is the injury to the endothelial lining of the blood vessels or stagnation in the flow of this. This is called as a virtuous triad, which may lead to formation of the clots inside the deep veins of the legs. So this is commonly seen when the patient is having additional factors. Many factors are there that can lead to DVT. So it depends upon the different criteria,
Okay,
a lot of
so
criteria.
what's DVT prophylaxis in surgical patients, or how to prevent DVT in surgical patients?
Yeah, in most of the time in pre-operative, intraoperative, and post-operative. Pre-operative, you have to very much clear about the patient's age, patient's obesity, then all the signs we have to see for atherosclerosis or anything. And then intraoperative, we can apply for the surgery has to be done meticulously. It should be short time. Then the patient should be applied with the thromboembolic deterrent devices, TED stockings or mechanical massager devices just to be applied to the thigh. And post-operative, the same has TED stocking should be continued, and early mobilization, that is mechanical movement, has to be done as early as possible.
Okay, so what the mechanism of action of heparin?
Heparin, it acts on the clotting factors like it prevents coagulation inside the low molecular weight
Hello?
heparin and the unfraction.
So which pathway will be affected by heparin? I didn't get your answer because there's connection problem. So which pathway affected by heparin?
Intrinsic pathway is affected by the heparin. The pathway
Okay.
which involves
So how to monitor heparin therapy?
heparin has to be monitored by APTT, measuring the APTT and bleeding time.
Hello.
Yeah, I'm getting voice.
Yeah. So if like still we have this issue here. So what the presentation of renal cell carcinoma?
My voice is cracking, or is it clear?
I can hear you now. Yeah.
Okay.
So
So,
the
so
presentation of renal cell carcinoma.
So generally renal cell carcinoma, if it is a very large size, it can be a palpable lump. The patient is having most of the time painless hematuria and paraneoplastic syndromes like thrombocytosis, this blockage of the clots and all that. So most common sign is the palpable lump as well as hematuria.
Okay. So in male patient, how they present if they have renal cell carcinoma?
Your voice, I'm not getting sound.
Male patient. So what is other symptoms like in male patient with renal cell carcinoma?
If it's present on the left side, that can compress. The renal cell carcinoma can extend inside the renal vein, leading to the varicocele on the left side. Most of the time, it is possible on the left side. Right side, it has got unless and until it has invaded the inferior vena cava. So this varicocele is one of the signs.
Okay, so we're going to stop here, Dr. Hamid. Thank you so much. I think we're still having the problem actually. Thank you so much. So is my connection? They're saying is my connection actually is not yours, Dr. Hamid.
Okay, actually, I was not understanding. Is it from my side or that side? But it's nice to have
Actually, I
this.
changed my. I moved a little bit, but I'm going to move again. But I don't know. So what about now, guys?
لا كانت أحسن. It was better before.
It was better before.
Yeah.
Because I was moving a little bit, so until I got like good connection. Especially in the communication part, actually. I'm going to give you the mic to give him the feedback to Omar after I give him feedback, because I didn't hear anything about the communication, actually, to be honest.
Oh, okay.
But like go through quick feedback to Hamid, okay?
Yeah.
So actually, you were acting quickly this time, actually. So last time you were very calm, Dr. Hamid. But this time, I think the exam is like
Exam has come close. That's why I'm thinking, trying to cover as
yeah.
much
So
as 17,
you're acting
17.
quickly. So most of the stations, so you're starting quickly. You like normally actually we have your last mock actually is much better. So you were calm, you were relaxed, you were like yeah. So just you need to. It's not that very bad, but pay attention to it, not to act quickly. Okay, especially when you enter the station. So your introduction, you entering the station, especially the first station actually. So you were acting quickly, and you forgot to ask about the tetanus vaccine. Then you forgot to check the wristband. Then you went to check the wristband after that, and yeah. So like you have to have your own template how you're going to start. So you are going to introduce yourself, confirm the patient ID, and check the response like straight away. So okay, and you have to be observant. If this response is red, so in this case you miss to spot that. So this 1 mark. If you spot this yourself, you are going to get marks. So you lost this mark because you asked me about allergy space, and then like so. So because the doctor is saying if you spot that the patient is having allergy from the wristband, that mark for you. Okay. So, like, enter the station in a calm way. So, I'm Dr. Hamid, one of the doctors or one of the surgical doctors. Can I confirm your name and age or date of birth? So, in the procedure, it's fine to ask about date of birth, and you can check straight away the wristband. Oh, so you have red wristband. So, can I ask what are you allergic to? Okay, so don't lose easy marks. Okay, and there are different ways. Sometimes you will be wearing your gloves outside the station, and sometimes you'll do the procedure without gloves, and sometimes you're going to wear the gloves inside the station. So, like, it depends on the exam date. Okay. Yeah. So the main concern here was acting quickly. So in trauma patient ask about X-ray. So like for foreign body and like even for fractures. Okay. So you forgot to ask about X-ray. And guys, try to make your introduction short in the procedure, because like now it happened to one of the candidates. He was taking long in the introduction and the explanation. You have to explain. Yes, you have to explain the task, but briefly. Because I remember one of the candidates said to me the examiner stopped him from talking to the patient. So there are communication marks in the procedure, guys. Yeah, you are going to be marked in the communication. So your technical skills, they're going to get 8 marks. Your communication and professionalism, 8 marks. So there are 4 marks for communication and 4 marks for professionalism. So the examiner said to that candidate, don't talk to patient. Actually, there are 4 marks in the procedure. So that doesn't mean don't talk to patient. And yesterday in the session, we showed you guys, you are not supposed to talk to the examiner or run commentary, but you need to talk to your patient. I showed you the slides and the what's recommended actually yesterday, if you remember. So you're supposed to talk to your patient, but don't take that long. So like, yeah, just talk to your patient, explain the task briefly, and go and prepare your equipment and prepare your things. And the safety issue was good actually. So the safety with like checking the expiry date and these things. Yeah, so like when you were tying, the needle was not like I couldn't see that the needle is moving or is not moving actually. So it's very important to pay attention to the needle safety. And I can tell it's not like I didn't see the needle moving actually, to be honest, because yeah, all through the connection is breaking. But like when you hold the thread from long end, you want to tie it with long end. There's a risk that you are going to move the needle a lot. So hold short end, short part, and tie with it. So the needle is going to be like safe. So pay attention to the needle safety, okay? And like take equal bites. So from the edges of the wound, take equal bites. So we can, this is just like general tips, but I couldn't see that. It's hard to see, but I know that you have the experience and you're going to do it well actually. But take equal bites, like 4 millimeters from the edge of the wound, and exit the same length, 4 millimeters from the edge of the wound. And when you tie your knot, avoid tying it on top of the wound. So just a little bit to the side of the wound, okay? So that will show good technical skills as well, okay? But your technique was very good actually. And if you are tying with Prolene, the first one, you can do it like three rows, okay? Or you can like to tie the first knot, do it 3 times and then tie. So we normally do it 2 times with silk, right? But if you're using Prolene, because it's difficult for Prolene, it's going to make your procedure difficult. So do it 3 times, okay? Actually, you asked, you mentioned your assistant. You said, I'll ask my assistant for something. But when you needed the assistant, you didn't use them. You didn't use the assistant to cut the suture for you. You didn't use them. So you can use the assistant. So if there's assistant in the procedure, use them. So, but you remember that you have assistant, because we didn't mention in the scenario in the STEM you don't have an assistant. So if you don't have an assistant, they'll tell you don't have an assistant. But in this case, we didn't tell you that you don't have an assistant. So you didn't use them. So you remembered, you said, I'll ask my assistant to do something for me. But again, you didn't use them. When you cut the suture, you cut it by yourself, okay?
Yes.
Yeah. So safety netting the patient is very important. So during you are doing the task, safety net the patient. Safety net the patient during you are doing the task, okay? Like the history. So guys, remember the very important things I've been repeating again and again, listening to this patient. So the patient mentioned, Dr. Omar actually mentioned he has something sensitive, or he has sensitive topic he wants to discuss with you.
Yeah. Yeah.
So like, I think that's what was going to get your diagnosis actually, and it's going, yeah.
Yes.
So you missed that. You ignored
Yeah,
it.
definitely.
Yeah. So very important to listen to your patient. And I think Dr. Omar, after I finish my feedback, is going to give you his comment as well. How did he like he feel about you? Yeah. So because he actually, I am surprised now when I do the station and I'm acting like the patient, I can give like better feedback actually from just
Yeah.
yeah. So we're going to give Dr. Omar just in a minute the mic to give his feedback as well. So listening is very important. Listening. Even he volunteered. So in the exam, sometimes he might not volunteer. Actually, the patient might not volunteer. You're going to miss the diagnosis and the management. But he volunteered. He said to you, "Doctor, I have sensitive topic I want to discuss." You ignore that. So listening is very important. Okay, listening is very important. And yeah, so so eyes is not a problem to ask about eyes, but like you have time. You have time in this case, but it's not a problem at all. But if in the long histories, you can just ask one question. Do you have any question or concern? Because in real life, we don't ask about it. And I have been to the prep course with the Royal College. They didn't mention anywhere, guys. It's important to ask about eyes. It's not something important. And in real life, we don't do that. Actually, we don't ask our patients from eyes what do you think and what you're expecting from us and what's your concern. So it's important to know the concern of the patient, but we don't ask them that way. So one question is fine, and most of our candidates, yes, they just ask that one candidate, and like again, the Royal College didn't mention anywhere, guys. It's very important to ask about eyes. I have been to the prep course and I had mock exam with them. No, it's not that important. It's nothing that it's not the important thing. So I showed you yesterday about the history, if you remember, guys. So chief complaint, that's the most important thing. Chief complaint, exclude the red flags, past medical, social, family, allergies, and you can ask about systemic review. So these are the important things, okay? Yeah. So I corrected you about something. So most likely the examiner is not going to correct you. I corrected you and I asked you to go back to your patient. So because he had sensitive topic he want to discuss with you. So normally the examiner, not all of them, some of them they're going to correct you. They're going to help you to go back to, if you still have some time, they'll ask you. So anything else you want to ask, okay? So they might do that, but like that not common practice in the exam. Okay. Yeah. So in the examination, you could have started. So you just assume that this patient is having right ear hearing loss. We didn't give you that in the. Did we mention right hearing loss? No, we didn't mention it.
Yeah, in the STEM it was written. Has a
No, hearing
on
loss.
the right ear.
Right.
Ear, something was written on the right ear. That's why I
No.
checked
It's
this.
just hearing loss. It wasn't the right ear, actually. So pay attention to the STEM is important as well. So in that case, let me have a look to make sure that like yeah. So if you were right, you are going right. So emergency department, hearing loss. Otherwise, well, please examine. No, it wasn't written perhaps. So it's very important to pay attention to the STEM. Okay. So it wasn't written in the thing. Nothing here is about writing it. Okay.
Okay. Yeah, sorry. That's
Yeah.
why
So,
I
yeah.
thought
So it's not written. So don't assume things, guys. Okay. So just ask the patient as simple as that. Which is your better hearing ear? Which is your better hearing ear, and you can like do your examination. Okay. Yeah. And actually, I think you mentioned that you like. So there's echo to Omar. So can you mute yourself and then we can like give you the mic after
Oh,
you
sorry.
finish the point.
Yeah. Sorry.
Thank you. So like you can start like as simple as that. Just ask the patient which is your better hearing ear. So you know which one is the affected ear, right? And when you did, so which is your better hearing ear? When you did the whisper test, you can ask the patient to cover one ear or you can cover one ear for the patient. Either way, so you can ask the patient or you can cover it, okay? So you were just whispering a number on this side and that side. So ask the patient to cover. I don't know if you are sure about this maneuver in like from one of the books is fine. But the maneuver I know is to cover one ear, one side, and whisper the number, and cover the other side and whisper the number, okay? And when you ask the patient about so this release, which one is Weber test? So did you ask the patient? Yeah. So did you hear that? So you said to the patient, did you hear that? So the answer might be yes. But I again corrected that question. I said it's loud on the right side. But your question has to be clear with the patient. Did you hear that? Yes, the patient can hear that. But is it louder in one side or equal?
This side.
So it's important the way you ask the question. So you just ask the patient, did you hear that? Okay. And you mentioned in your summary there was butter sign. Did you see it? They're not going to bring a real patient with butter sign to this exam, Dr. Hamid. So
Okay.
carefully, if it's not like present, don't mention it.
So injury, if any patient is
Just
giving the
present it.
history of injury, if it's not present,
Yeah,
you
So
should not mention.
the history is something, but yeah. So you can say that in your summary. So this patient presented after an RTA or after having fall or something like that. The patient presented with, but your findings, you have to be honest about them. You have to be honest about your findings. So what you found in this patient, you're going to mention it. Okay.
Okay.
And I remember one of the colleagues who had this station. So in his summary, like he was doing his summary, he said to the examiner at the end of the summary, there was hemotympanium. So the examiner laughed at him and asked him, just you can wait until I give you the picture, then you can say hemotympanium. So like yeah, don't show them that you are cramming the station. Very important. Don't show them that you know this. Yeah, okay. So don't show that to the examiner.
So this is what happens
In the communication.
when
Yeah. So in the
when you
communication, I'm
get
going to let
a
Dr. Omar, like because I didn't hear much of the communication actually, but the using of the using of your hands, like you was using hand like that. What I saw, but there was like your voice was breaking. Okay. Like yeah. So, but the using of your hands. Remember this, Dr. Hamid. The using of the hands. It has to be appropriate. So I think you use your hand like that. Yeah. So a lot in this. Yeah. So I'm going to give you the mic to comment just 1 second. So the examination of the shoulder, the exposure was late. So you remember the exposure late, but yeah, and it wasn't clear that you were maintaining eye contact when you were palpating for tenderness. It wasn't clear for me in the camera. On the camera, I don't know if it's still the connection problem or like you didn't maintain eye contact, but it wasn't clear that you maintain eye contact. So you have to do these things clear. The examiner is looking at these things. So the examiner will mark you according to what they see. Okay. Uh, and yeah, if you finish before 6 minutes, don't go to the examiner. Just stay with your patient. After you hear the bell or you are happy about everything you did, you can like go to examiner. But otherwise, stay with your patient until the bell ring. Okay, you might remember something and go back and do it. Okay. So in the summary, in one of the questions, like you answered very long answer actually. So try to answer in points, guys, especially in the knowledge. In all the exam, answer in points. You don't have to give like details. So just answer in points, okay? Don't give very long answers, okay? So Dr. Omar, I'm going to give you the mic. Yeah, so to give you feedback as well.
Yeah. So I think the first thing was that I think Dr. Hamid, you thought that the station was a history taking station, or it
Yeah.
was partially history taking, and yeah. So with the history taking, yeah, this was only A, gaining consent, and then explaining about the hip replacement. So so you didn't need to take a history, but even before then, didn't confirm my name or details or ask to gain consent about to speak to me. You just went in, assumed that I'm Mrs. Brown and whatever, and then you just fired away with your explanation of the hip replacement. So that was a big fall, but I think that was because you didn't realize it was history taking. Sorry, it was a communication station.
communication. Yeah.
Yeah. So yeah, when you know that, yeah. So again, just like Dr. Ali said, read the
Got it.
stem.
Got it. Actually, I
Yeah.
need to ask, are you Miss Hema or something like that? I just need to ask. Actually, I thought name is already given, and this is, I just want to explain. That's why I started. But what you told exactly, I need to ask, are you Emma? And you are like this. Got
Yeah,
it.
you need
Thank
to
you.
ask first and then gain consent. And then, first of all, and then the next point is to, before firing off into explaining the procedure, ask, like, how much do you know so far about the procedure? I might say a few things, but I will eventually, let you explain it the way you did, which was fine. No, you did pretty much. It was okay. I would have. We kind of wasted time with the questions because you were asking a lot of questions when you didn't need to. So it cut away from me asking, "What do I do after the surgery? Like, what are my do's? What are my don'ts for the surgery?" And yes, the alternatives for the surgery. You didn't fully go through it. Like you didn't go through physio, maybe I think potentially also joint arthroscopy to look at the hip. I think that might be a thing. I'm not I can't remember it fully. Osteotomy. I think if they remove or shave any part of the hip bone that's a little that's got wear and tear. Corticosteroid injection, I think, is another thing too. So again, because you weren't fully aware of the nature of the station, you thought it was a history taking and not so much. I think you switched up like a third of the way in, and you realized that this is communications and not history. So I don't think you were fully prepared for that. But with the questions that I did ask, the rest of the questions I did ask, you did handle it well. Like, when can I drive? What are the complications? How do you prevent blood clots? What are the warning signs and things like that? So the rest of it you kind of handled well. But yes, you need to confirm who I am, my details, and then gain consent to speak to me about it.
Yeah, actually, like as I mentioned, I was having a problem with my network, but if I interrupted you actually, so and I asked Dr. Hamid, do you want to see the stem again, Dr. Hamid? But like,
Yeah.
I don't know if
Actually, I got that.
Because I had-
That was a
yeah.
communication station, but I have seen some of the videos. They are starting with taking the history. That's why I
No,
tried
just
to cover
ask the
it in
patient
short.
understanding. So ask the patient. So this patient is already diagnosed with osteoarthritis and like plan for surgeries. You want to
Yeah,
learn
that's
about the surgery, yeah. So that's the
got it.
task.
Got it.
And even it's mentioned, do not take history. It was mentioned in the script. Do not take
In
history.
bold.
Do
Yeah.
not do examination. So
Yeah.
like carefully look at the scenario. Okay, they mentioned that do not take history. Do not do examination. It is communication station. Okay. Yeah. All right. So any question, comment?
So few of the questions before appearing for the exam. Out of 17 stations, what is your idea? Means how many stations the actors or the examiners are very much disturbing or irritating? You expect we should expect like angry
No,
mother.
it's not that much in one or two stations. Sometimes,
Generally,
no, yeah, sometimes none. Sometimes none. They're
none
going to be
also.
very small.
So,
Yeah.
this is when appearing for the exam, we think that every time the examiners or the actors are against us. So, in that with that tempo, if you go, we are already afraid of lot many things.
No.
So, whether he is going to,
Sometimes even you'll be surprised with the actors. So they're supposed to be angry and they're not angry. So
Yeah.
okay,
you'll be
okay,
surprised
okay.
sometimes
Yeah.
about that. Yeah. Yeah.
Like
So just be
with
prepared.
the
Just be prepared. Yeah.
Yeah,
Yeah.
like
So
with the MRCS, it's I mean, maybe for those who've sat the plab, some of the actors are a little bit. They're trying to rattle you. They're trying to
yeah.
see if you can, start to panic and stuff like that. But not in the MRCS. They're not as like mean or as nasty.
Yeah. So
They're quite
even
helpful.
sometimes the angry patient, they're not going to be angry. You will be
Yeah,
surprised.
yeah.
Some of them they're going to be angry, but like some of them they're going to be
It's
very, very,
for a
very
very
calm.
short time. Yeah.
But just be ready for the worst scenario for every scenario.
Yeah. In some of the abdominal pain patients, they don't allow us to touch even. In that case, we have to stop in between and just come with the
Yeah,
other
so just
things.
communicate well with your patient and try not to cause more pain to your patient. So that's very important. Sometimes they'll do this to see if you are communicating well or not. Okay. Yeah. But if you communicate it well and the patient still cannot tolerate the pain, you can stop the examination. Yeah, that's fine. You're not, yeah. And say to the examiner, I couldn't do this and that because I don't want to cause more pain. But before that, communicate well with your patient. Try the communication, communicate well with your patient, and then see how the patient is going to respond. Okay. Yes, Dr. Isao.
Thank you very much for the opportunity. My question will be that for each station, will it be labeled that is a communication station, like on the stem? And then I have a confusion about the timing for each station.
So it
Yeah.
was clear actually. Do not take history. Do not do examination. This is communication. That's what's written on the stem actually. Like do not take history. Let me show you the stem again. So do not to take history. Do not do examination. So this is communication station.
And-
Let me
all
show
right.
it to you again. Yeah.
And then the other follow-up question will be about exposure for examination. Like a shoulder examination, what was the right exposure? And then for the ear examination, what's the right exposure? Or
Actually, so the if you look at the last one, this is communication station, and if you look at the top, so that like here it was mentioned, you don't need to take detailed medical history, perform physical examination, obtain written consent. This is communication station, so you do not need to do that. Take consent or do physical examination or take history. So just communicate with the patient. Okay.
all right, thank you.
Yeah, for the exposure, normally the patients in the like if they have upper limb examination or abdominal examination or chest examination, they're going to be wearing gown. So just ask them to take off their gown. So as simple as that. So the patient will be wearing gown most likely. Just ask them to take off their gown. If they are wearing like for the knee, it has to be like till the middle of the thigh. So you can ask them to roll up their trousers, roll even to take them off, but like if they're wearing like trousers that can roll up until the middle of the thigh, that's fine. They can roll up their trousers until the middle of the thigh. Sometimes we'll be wearing gown, so you can just tell them like roll up your gown in the middle of the thigh, so that will be fine. Okay.
Yeah, and for examination station, I've heard that many a times you have to do a general physical examination before you go to the real examination. So is it every time you do that, or you just go straight?
So it's very important to look around. Very important to look around what present in the state, and that's a fair thing. So look around, look at the table, so you will understand what you are going to do. Have a general look. Yes, so in every examination, have a general look at the patient. Make sure the patient is comfortable. But don't waste your time in detail, like you want to do the pulse and seeing the color and the opening their mouth and see the tongue and these things. No, not for every single examination. So if it's knee examination, go and do the knee examination. So just look at the general appearance of the patient, make sure they are comfortable, and then go and do the rest of the knee examination. In the abdomen examination, yes, do the general examination. Look for the hands, look for the eyes, look for the tongue, look for the chest, and yeah, look from the end of the bed, and then do the rest of the abdomen examination. In the respiratory as well, you can do that. In the cardio examination, you can do that as well. Do the general examination and then go to the respiratory or the abdomen or the cardiac examination. Okay,
Yeah,
not for
in the
every
event
single examination.
in the event that you are making a palpation and the patient is in severe pain and cannot tolerate, cannot continue the exam, what do you? Is there anything you are supposed to do?
So for example, suppose this happened in the exam. So suppose you are doing like we want to do rebound tenderness, and like the patient was like saying that he's having severe pain. So and this like from the exam, I just mentioned this yesterday. So if you remember the station yesterday, the session yesterday, so I mentioned it. So one of the colleagues who had the acute appendicitis, in their exam, most of the candidates they said that the actor was not cooperative. There's one of the candidates who said the actor was very cooperative actually. And the difference between them, so that one who said the actor was cooperative, he was communicating well with the patient. Before doing the rebound tenderness, he said to the patient, "This test is painful. I'm going to press a little bit deeper, but it's important." So he allowed him to do the rebound tenderness. He didn't allow the other candidates, and he allowed him to do the Rofsing sign, but he didn't allow the actor didn't allow the other candidates. So even sometimes they want to check how you are communicating with this patient. So communicate well with the patient, you're going to get there. Even if you communicated well, some scenarios the patient might have acute injury. Even after communicating well, the patient cannot tolerate the test, so stop it. That's fine, don't do it. But communicate well with the patient first, and then try to proceed carefully. Try to proceed carefully. If the patient allow you, carry on. If you still cannot tolerate, stop the examination and just explain to the examiner after your summary that I couldn't proceed with this. And explain to the examiner what you want to do, the special test, these things and these things. I couldn't proceed with them. because I don't want to cause more pain to the patient. Okay.
All right. Sorry. My last question, so that others can ask their questions. Please, can you help with the timing for each station? I always
Each
have
station is
confusion
9
whenever I
minutes.
practice.
All the stations are 9 minutes. So 1
9
minute
minutes.
outside the station for the stem and 9 minutes inside the station. All of them are 9 minutes. But if you are doing history and examination, you are going to stop in 6 minutes. If you are doing history or examination, stop in 6 minutes and go to your examiner. Thank your patient and go to your examiner. But the rest of the stations, you are going to.
So for the history now, you use one.
No, for history, you are going to stop at 6 minutes.
For the
So the station is 9 minutes. But
so for
take
history,
yeah,
history,
interact with the,
for history. Sorry for cutting. For the history, you stay outside the station for 1 minute. You read the question. You
yes,
take the history for 6 minutes. That's
Mm.
7 minutes. Then you have 2 minutes to do your summary and take questions.
for 3 minutes. Yes.
Oh, sorry, 3 minutes. So that's 9 minutes in total.
Yes.
All right. Thank you.
Yeah. Yes, Dr. Hind.
Yeah, thank you very much for this mocking. I have two questions. The first question regarding the pathology station, regarding the presentation of renal cell carcinoma in male. And my second question regarding the cranial nerve examination regarding the hearing loss. Is that a station that the patient in emergency, because it is mentioned the management would be according to CREST protocol? Just I want to clarify this.
Okay, so you already examined the patient and the patient sitting in front of you. So, like, yeah, so I didn't comment on that. So it's not necessary to mention that ATLS protocol and these things. So just managing this case now. So much is going to include the ENT and the neurosurgery actually. Okay, that's fine. That should be enough. Okay. So like, just 1 second, guys.
And my second question
Just
regarding the renal cell.
1 second. Yeah.
Okay.
Yeah, sorry for that. Can you ask your next second question? Sorry for that.
Yeah, my
Someone
second
knocking
question
on the
regarding
door, yeah.
pathology station about the presentation of renal cell carcinoma in male. What the presentation is? Is it the same previous triad or they have a different presentation?
Yeah, so it's like the sorry for that because I like someone knocking on my door as I mentioned. Sorry for that, guys. So it's going to be varicocele on the left side. When it's on the left side, it's going to be varicocele. So that's like yeah, in male. Okay.
Okay, thank you.
You're welcome. Yes, Dr. Hamid.
I just want to ask a few things about the stations like crisp examination in examination part. When you have got a station where pulmonary embolism, anastomotic leak or something, in that should we go and ask for the charts initially or what to do for that? One
Yes,
thing.
you can ask. You can ask. Sometimes they'll provide you with the chart from the beginning. Sometimes they're not going to give you the chart until the end. So you can ask. And sometimes the chart will be in front of you. Just go and take it yourself.
And here, if we can we ask to the examiner whosoever is sitting, if you want to measure the BP, because as we go for the circulation and we see for the BP, so if
No,
blood pressure is not there,
no,
apparatus or something,
no,
is it not
no,
there?
no. Don't interact with the examiner. Don't interact with the examiner. Yeah. So just say to your patient, "I'd like to check your pulse. I'd like to check your blood pressure." That's fine. Okay. But you are not supposed to interact with the examiner. Okay.
Okay, so in that we should not ask with the interact with the examiner. So do we have some assistant in such such
No,
cases in examination? They don't
no,
have any other person. So
no.
it
There's
is
no.
a
No.
candidate and the patient and the examiner. So here
Yes.
we cannot talk to any other person during that only
No, no,
patient
no.
and the candidate.
Sometimes there might be interpreter. So if there's interpreter, the patient might not. So sometimes they'll.
Okay.
That
That
case, yeah.
important thing which I was thinking, suppose in a history, when we ask, can I know your name and age? So can we add from where you belong, means the location, the place, so that sometimes can we use some of the words which patient can understand, the language, sometimes it can happen. Is it allowed?
No,
It's not allowed.
no.
So
Just in
because it's a
English. Yeah.
communication, actually what I am asking, because most of the companies, when they ask which languages you know, if suppose the
No.
patient himself is I am an Indian, if he is Indian, so can I use my
So are you
language?
going to
Because
take
it's
the
a
history in your language then?
so
The examiner is not going to understand anything you have.
that is the communication skill. So it's easy to understand what patient and what we are telling patient. It's not allowed. So
No.
any other language, even if you are knowing that patient is understanding its language, you cannot use it.
No.
So that is one thing. And one thing, last thing. What is there any dress code, and can we wear the watches to measure something like a pulse or something? Is it allowed?
So smartwatch is not allowed, but the normal watch is allowed. But don't even the normal watch, because you are not supposed.
No,
You're supposed to like nothing below the
just
elbows. Yeah,
so
nothing below
just do
there.
the
So
acting of
don't
measuring
don't
the
wear, don't wear
pulse.
watch or nothing. Yeah, so just like even no rings. Wedding ring is fine, but like nothing. Okay, just the wedding ring.
Okay.
You can wear the wedding ring. Apart from that, nothing. Okay,
Okay, thank you.
you're welcome. Dr. Yisau.
Yes, just a clarification. For the abdominal examination, you are doing a general physical examination. You put the patient in cardiac position. Then when you're about to examine the vitreous node, you remove the shirt, and then when you're done the abdominal examination, you tell the patient to be you put the patient in supine flat position. You change and then you expose the whole shirt to how do you now do the exposure for the abdomen? Is it that you cover from the nipple line and above and tell the patient to pull their shorts till the mid thigh?
If the patient is female, yeah, it's better to cover the nipple. Yeah, so if it's female, but if male is fine, just carry on.
So, what about the sanctity of the patient, like the privacy area? Like, are they supposed to cover that, or that's the dilemma?
Yes. So they like supposed to cover it. Yeah, to keep the patient dignity is important. Yeah. But
So
anyways, as I
that means
mentioned, don't complicate things, doctor. Like you're just going to ask the patient to remove, take off their gown, or roll up their trousers, so they'll be prepared. So because there's no time to think about this exposure, they just want you to do it. So if you need to take their gown, you can ask them to take their gown, to roll up their trousers. So with keeping dignity. So you're not going to like overdo the exposure or expose unnecessarily. Okay. So like it's going to be simple. The patient in back examination, for example, is going to be wearing a gown and short. So just you are going to ask the patient, and you can see that. So just take off your. So that the most common in the exam, most likely is going to be like that. Okay, can I ask you to take off your gown? And sometimes even they might refuse to expose. Like just you have to ask the patient to expose. It happened to me personally. So I asked the patient to take off her top. She refused, and I just continued the examination. So like you are not going to insist. Even the examiner, instead of saying to me like proceed, he was like, "You don't have time for that. Like go and do your examination. So you don't have anything else to do apart from like that." Like was a permission, but in a rough way, if you understand. Okay. So I asked
okay.
the
So,
patient.
but sorry, from what I understand from what you are saying, it's just important to just run a commentary and say, I would like to expose my patient from the nipple line to the mid thigh.
No, don't run commentary. No. Just ask your patient. Never run commentary. So that's not allowed in the exam. Just ask your patient, can you take off your gown? Can you roll up your trousers? Can you yeah, what part you want them to expose? Like, and make sure you like cover the private part and like maintain the patient dignity. And the patient is going to be ready. Don't worry about that, doctor. So the patient is going to be ready. Just wearing gown. You need to ask them to take it off. That's it. Most likely the patient is going to be wearing gown. Okay, so don't worry about this exposure.
All right.
But Isaac.
Okay, Dr. Hallam, thank you for moderating this important section. I just wanted to ask, must you always ask for a chaperone when you're doing any examination with abdominal, respiratory system or cardiovascular system?
No.
Must you
You don't
always
need to
ask
ask.
for a
You don't need
chaperone?
to ask for chaperone for any one of the stations. This is what the Royal College is saying. You don't need to ask for the chaperone. The examiner is your chaperone. You can just tell your patient there's a chaperone during my examination. You don't need to ask. Okay, you don't need to ask. The examiner is your chaperone. That's what the Oracle is saying. So the examiner is your chaperone. So just tell the patient there's a chaperone during my examination, there's a chaperone during my consultation. Okay, Dr. AJ.
Okay. Okay. Thank you.
You're welcome. Dr. AJ.
Hello, thank you, Dr. Ali.
You're welcome.
Hello, thank you so
Yeah,
much, Dr. Ali.
you're welcome.
I in my last, I think where I think I had the problem this last May, I think it was my first station. So the minute I just came, it was a case of chest tube insertion. So I was told if the man had not told me that the patient had been draped, anesthetized, maybe I would have just done my thing the way, but I think that's where I had the problem. So I was just thinking that kind of situation when we're told, it was a mannequin that I should determine the where I'll put the chest tube, and after doing that, then I should put the chest tube. I should just put the chest tube drain. That I should do the procedure. In that kind of situation, how am I expected to go about it? I don't know if you can just briefly highlight that.
Yeah. So actually, the test tube normally is going to come through. So they're going to give you the scenario outside. So the patient will be anesthetized and everything done and everything checked. Okay. So you're going to enter. They're going to show you an X-ray. They'll ask you about the X-ray.
Yes, that was the first question. The X-ray.
Yeah, the X-ray, and they ask you to define pneumothorax and the cause of pneumothorax and indication of chest drain, and then you're going to go to the mannequin. So you're not supposed to communicate with the mannequin. And if you listen to the examiner's question, the question was, talk me through the procedure. So that procedure you're going to run commentary because the examiner asks you to talk through. In the rest of the exam, you're not supposed to run commentary. But if the question, talk me through the procedure, you're going to speak to communicate with the examiner because there's no patient. And so, and I remember when I had it at the course as well with the Royal College, it was like that, talk me through. So you are going to say, I prepare my equipment, including underwater seal. So my safety. So you're going to speak. During my speaking, my safety area is the 5th intercostal space mid axillary line. So you are counting at the same time and saying that. I'm going to determine the 5th. So I'm going to confirm. So don't forget to mention that. I'm going to confirm the site by clinical examination and chest X-ray. Then I'm going to determine the safety area, which is 5th intercostal space, and you're counting for the 5th intercostal space mid axillary line. Okay. Then I'm going to do stab incision, then blunt dissection, and you are doing that during you are performing the procedure. You are doing that. You are doing stabbing incision. You do blade, and I'm going to do you are not going to look at the examiner and doing the procedure. No, look at the mannequin and run commentary because the examiner allowed you. That's the only case in this exam you're supposed to run commentary. I'll do stab incision, then take your artery forceps and do then blunt dissection. Put your artery forceps, set your finger. So then I do sweeping to ensure there's no lung tissue adhered to the chest wall. Okay. Then take your chest tube. So it depends, the size depends whether it's pneumothorax or hemothorax. In pneumothorax, you can use the small one. Hemothorax, you need to use the large one. Don't use a tube with a trocar. So if there's trocar with the chest tube, you're not allowed to do it that way. So remove the trocar and insert it with the artery forceps. So take the artery forceps and insert the chest tube. So in case of pneumothorax, and most likely in the exam is going to be pneumothorax, so you're going to go toward the opposite shoulder, right? Then until you insert all the holes inside the chest, then you're going to secure it. So mention that I'm going to secure it with the suture and then plaster and then to connect underwater seal and X-ray. So these are the, how they're expecting the chest tube to be. Okay, they want you to insert it in that mannequin physically, so the mannequin will have hole on that side covered with silicone. Okay, you're going to do your incision on that silicone. You're going to insert it and you're going to suture on that silicone and fix your chest tube. Okay.
Yes, there were many tubes there. They were like 7 or 10.
Yeah, so in pneumothorax you can go for 20 for the small one. Your size 20 is okay. So just go for 20, the small one, and that's okay. That's fine. Okay.
So I'm not supposed to speak with the mannequin, just run through.
No. So just walk through or talk me through that how the question. Listen to the examiner's question carefully. So the examiner asking you to talk me through. But in the other procedures, when there's a patient, you are going to talk to the patient. But in this one, like because I had it and I know how it run actually. So
It
it's
was
going
very
to be
painful.
talk me through the procedure. Okay,
Thank you.
I'm supposed to take 2 minutes. So any question we can take one last question, guys, and we can take one last question. I think no other questions. So thank you guys. Thank you so much. Thank you, Dr.
Thank you
Hamid.
very much, Dr. Ali. Thank you very much. And your last opinion, any last message? Because before exam,
No,
what you have told.
I'm going to contact you, Dr. Hamid, because I promised to do something with you before your exam. Yeah.
Yes, definitely. Thank you very much.
Keep
Thank
in
you.
my promise. So I remember from the last book, I mentioned that we are going to do something before your exam. Yeah, so I'm going to get back to you, Dr. Hamid. Thank you so much. Thank you, and I see you next time. Thank you, guys. Bye. And good luck, Dr. Hamid. Yeah. Bye. Thank you.
Thank you, Dr. Ali. Thank you, everybody.